most of the studies or all the studies done on microvascular function testing were done on native arteries, not bypass. Yes, sometimes if the symptoms recur after unroofing, we may opt for one or two things. We either try to treat endothelial dysfunction and treat for spasm, because that's what wasn't treated by surgery. Or we can, if we want to be more targeted and more precise, we go back to the cath lab and we repeat the studies.
Welcome to Imperfect Heart, a place for you to join me, Jeff Holden, in conversations, discussions, and dialogue about our hearts and the impact myocardial bridges have on them. We'll talk with healthcare professionals, those in related fields that support our condition, and others just like us with stories of their myocardial bridge experiences. It's my intention for this content to inform, educate, entertain, and even motivate or inspire you in your personal journey on dealing with a myocardial bridge. Most importantly is to have you leave each episode with hope, knowing you're not alone and that what you're experiencing is real. Just a quick reminder before we get started that the book is now available at Amazon.com, Imperfect Heart, Stories of Myocardial Bridges. Buy it for anybody who doubts that this condition is symptomatic. I'm excited to share our next guest with you as he's going to give us a little perspective on a topic I'm hearing more and more about, and that's recurring symptoms post-unroofing. Is there a way to better understand why this is happening, what can be done, and what is the outlook for those who have had a recurrence, or worse yet, no improvement after surgery? Ours is a complex issue with every case unique and the condition dynamic or ever-changing. The gentleman we get to hear from is with an organization we have never had a representative from, and that is the Cleveland Clinic. You're about to hear from a leader in interventional cardiology and a specialist in microvascular disease. Dr. Khaled Ziada is co-director of the Coronary Artery Disease Center and chief academic officer for cardiovascular interventions in the section of invasive and interventional cardiology. He represents the most contemporary diagnostic testing for endothelial dysfunction, coronary vasospasm, myocardial bridging, and microvascular disease. He has performed more than 7,500 coronary and peripherally invasive procedures. He's participated in over 30 research studies, has been published in numerous research papers, and speaks Arabic in addition to English. I am honored he has taken the time from his incredibly busy schedule to speak with us. A friend to the Imperfect Heart community, Dr. Khaled Ziada, welcome to Imperfect Heart.
Thank you very much, Jeff. It's a pleasure to be here.
We are honored because you're also the first guest that we've had from Cleveland Clinic, and you are one of the premier institutions for interventional cardiology and certainly with myocardial bridges and now microvascular disease as well. So we are really anxious to hear what you've got to say. Dr. Ziada, we've had several episodes where we've discussed the nature of the role of the interventional cardiologist and how significant the process is in proper diagnosis. The one thing that appears that's happening is that patients are forgoing the provocative testing. They get the diagnosis through a CT angiogram. They can identify they've got the bridge, and even surgeons are performing the surgery. But unfortunately, they're coming out with less than significant results, I should say, and in some cases, subpar results. And the expectation was much higher. They still have symptoms, and they grow concerned. As we're recognizing now, we know more about the nature of blood flow and routing in our hearts, and the more likely we are to find the true cause of the problems through the provocative test. The bridge may only be a part of it, and in some cases, maybe not even the culprit. Can you give us your thoughts on that?
Yes, of course. I'm happy to do that. And you pointed out this is an important subject. Myocardial bridges are very common, yet only a very small fraction of them are really hemodynamically significant and can cause symptoms. So for the majority of time, when we see bridges, they are what we call bystander findings, meaning they're there, but they're not causing any problem. But we today are talking about the ones that are causing problems and causing symptoms and affecting blood flow. And bridges can affect blood flow in more than one way. So I think this is what you were alluding to, that this is a bit of a complex issue. It is not an automatic or a straight line from finding a bridge to operating on a bridge to getting rid of symptoms. Unfortunately, it is not that straightforward.
Mm-hmm.
So bridges can cause symptoms in multiple ways. Let's step back and think about, why is there a bridge? There is a bridge because there is some developmental anomaly in which the coronary artery and the myocardium develop together while in the embryo, and the coronary artery develops on the surface of the myocardium. But for some reason, in this case, the coronary artery channel or lumen developed within the myocardium, or some myocardial tissue developed around it. And that means that the artery is now encased in myocardium, partially or completely, but within some pressure or some encasement of myocardium. What that does mean to us is that the development of that segment of the artery is slightly different. And so the endothelial function, or the endothelium, or the lining of the artery, and all the wall layers of the artery are slightly different and not perfectly normal. That becomes important in the development or in the subsequent phases, because we realize that the issue is not just the geographic location of that segment within the myocardium, but it's actually the nature of that artery itself. So what that means that when we do myocardial bridge surgery, which is basically releasing the artery from that encasement, we take that artery from within the myocardium to the surface of the myocardium, where it's supposed to be. So no pressure, no compression on the artery when the heart is contracting. However, we have not changed what's inside the artery. We have not changed the layers of the wall of the artery. We have not changed what we call the endothelial function of the artery. So some patients with myocardial bridges have endothelial dysfunction and have a much higher tendency to have coronary spasm. And that may, in fact, be the primary reason why they're having chest pains or having symptoms. It could be that in some bridges, the spasm is much more relevant to their symptoms than the compression. And it could be that some bridges have only compression that's causing the problem and very minimal effect of endothelial function. And so it could also be relevant where the bridge is, how many branches are coming out of this bridge, how deep is the bridge. So a number of things, how long is the bridge? So a number of factors come into play as to the significance of that bridge and what is the likelihood that that specific bridge and that specific patient is causing the symptoms. So that's what we are trying to advocate for, is that we need to study these bridges in full detail before we do surgery on them. And the reason for that is that if we study them in detail, we will probably be able to identify the ones who will benefit the most and the ones who will benefit the least from surgery. And if we identify those, then we will, one is set the expectations correct. As you pointed out, there's an expectation issue. And then the second thing is obviously only treat the patients who we think are going to benefit. After all, whether it's minimally invasive or not minimally invasive, it's still heart surgery. So it's still something that we need to approach with caution and with, full attention to detail.
Yeah, surely we're working on somebody's heart. There's nothing to be taken lightly in any consideration, even though it's a relatively simple procedure in some ways, but the significance of it is it's your heart. And
that's right. And I would maybe make a comment on what you said about simple procedure. It is simple, but it needs to be very precise. So it is not something that most surgeons do. And so it is important to have some experience in how to do this and what are the important steps and important potential mistakes that one can make so that the surgeon can avoid them. And that comes with some degree of experience. So I think it's important when we talk about referring a patient to have bridge surgery is to make sure that the surgeon that we work with have some degree of experience.
Well, and you mentioned something else too, in terms of the actual testing procedure. What is revealed in the test is branched arteries that could be being compressed. specifically the endothelial challenges, which may be a greater significance than actually the hemodynamic compression of the heart. So we've got all these things that are significant in part that come from the testing procedure and help the interventional cardiologist like yourself, as well as the identification of what the surgeon's going to do if, in fact, there is going to be a recommendation to surgery. And many of the people who are listening, they've heard now several iterations of the significance of the provocative test. But I think what they haven't heard is all these variances of the revelation from the test. Is it endothelial dysfunction? Are you severe endothelial dysfunction? Is the compression significant? Are you blocking 100% on compression or compounding all of that at one point in time, a spasm, a compression, and I would imagine that is ischemia for sure. But beyond that, now that we get past the identification of the endothelial function, the identification of the significance of the compression, depending on where that artery is, or arteries, down to the next step, and that's the microvascular side of it, which could also be an issue, and in some cases the issue, correct?
Correct. You are correct. So the tests, so they are actually, when we say provocative testing or microvascular testing, we're actually talking about a series of tests that are done at the same time or one after the other during the procedure. They may be separate tests, but in combination, they answer all the questions that you just alluded to. So the first thing is we identify, is there a bridge or not? You can know that from CT, as you mentioned earlier. Sometimes you don't have a CT and you can identify that on the basis of the angiogram. When you see the compression of the artery with the cardiac cycle, with the contraction, and then the artery being released a little bit with the relaxation, and then you see this over and over, and you realize this segment of the artery may be intramyocardial. But sometimes it's not that easy to see. And so it's important sometimes, or many times, or almost all the time in these cases, is we use intravascular imaging. And specifically, we use intravascular ultrasound to identify where the bridge is, so that the intramyocardial segment has a specific look to it. There is a halo of heart muscle over it. The artery itself seems to be restricted or compressed. Its motion is not just relaxation contraction, but seems to be wobbling a little bit, because the heart really doesn't contract in press, unpress, press, unpress. There's a bit of torsion with the contraction, so to squeeze the blood out of the ventricle. So you can sometimes see that wobbling in the motion of the artery in the intramyocardial segment. And so you identify that there is a bridge pretty much more accurately, or most accurately, with intravascular ultrasound. Mm-hmm. Now, beyond that, you start looking at, okay, how long is it? You can see the segment of the artery that is dipping inside the heart muscle. You can see the artery in the heart muscle, and then you can see it come out of the heart muscle. So you can define actually the length of it. You can then decide or identify, where is that? Is it the proximal part, the topmost part of the artery? Is it the apical part, the very farther down the artery, or is it in the middle? You can identify how many branches are coming off that segment, because the branches are affected, and the degree of ischemia caused by the compression is affected by the number of branches. The branches are also important for the surgeon to know where the bridge is, because when they go inside the chest, they need some landmarks. So if you tell them it's 2 millimeters downstream from right branch, or 3 millimeters above that other branch, then they know where to look.
Okay.
That's another thing. The third thing is the depth. The deeper the artery inside the muscle, the more likely that it's causing compression and ischemia. So you want to measure that as well. And all these things can be relayed to the surgeons if we decide that's what we want to do, to help them decide where to go, how much to cut and over the artery, and how long, and so forth. So that's one part of it, is identifying that there is a bridge. Then the next thing is to measure the degree of compression. And for that, we use what we call dobutamine provocation or dobutamine stress. So the idea is dobutamine is a chemical that is chemically related to adrenaline or norepinephrine. Epinephrine or norepinephrine, the same, catecholamines. Mm-hmm. And dobutamine is more selective on the heart receptors. So it makes the heart contract harder and it makes the heart contract faster. So we start infusing dobutamine after we put a pressure wire across the bridge. So the pressure wire allows us to measure the pressure upstream and downstream. In the resting state, frequently you don't see any change or any drop in the pressure because the compression in the resting state typically is not very severe. Sometimes it is, but for the most part, it's not very severe. When you start stimulating the myocardium, which is kind of what happens with exercise, with activity, with climbing stairs, with running, with, carrying heavy things, with even getting emotionally stressed. That's what happens. Your heart rate goes up and maybe your contractility becomes a little bit strong. So then the bridge becomes more compressive. And so we start seeing a change in pressure between the upstream pressure and the downstream pressure. And the degree of change and how far the pressures separate tells us how significant that bridge is.
Mm-hmm.
We also look at what heart rate do we see the separation? At what blood pressure do we see the separation? Obviously, if that separation happens when your heart rate is 70 or 80, it means that this can happen to you every day with minimal activity. If it only happens when your heart rate is 150 or 170, it probably means that that happens when you are, in exercising to a very high degree. So all these things come into play as to understanding the compression and the hemodynamic significance of it. We also, after that, test for what we call microvascular function. So we use adenosine, not dobutamine. And what that does is that it opens up the microcirculation downstream from the bridge. And that allows us to make sure that the microcirculation downstream, is it healthy? Is it not healthy? Does the microcirculation, is it able to dilate and allow the flow to increase with stress or not? Because if it dilates and opens up nicely with stress, that means that fixing the bridge will lead to symptomatic improvement.
Mm.
But if there is a problem with microcirculation, that means fixing the bridge may be partially helpful and may not be helpful at all because the problem may lie somewhere else. And so it's important to know that the microcirculation is not the problem or is not the cause of symptoms. And then the other thing which you mentioned multiple times, which is provocative testing. Provocative testing typically means, in this case, we use two kinds of provocation, the dobutamine, which I mentioned, but also use the typical provocative testing for spasm.
Mm-hmm.
In our lab and in most labs, I think we use acetylcholine, which is an agent that we inject into the coronary artery, and we see the response of the coronary artery to that injection. The acetylcholine can induce coronary spasms in patients who are susceptible to it. And we know that the acetylcholine molecules work through endothelial receptors. They don't interact with the heart muscle, with the vascular muscle directly. They work through endothelial receptors. And so when there is endothelial dysfunction, the acetylcholine can actually cause spasm. And when there is normal endothelium, the acetylcholine causes no spasm or even some vasodilation. So when we inject acetylcholine, we typically see that the segment intramyocardial, the bridge segment, starts to constrict, starts to spasm.
Mm-hmm.
Because we know that this segment is most likely dysfunctional when it comes to the endothelium or the inner lining of it. And depending on the degree of that, is it severe? Is it 90% blocked? Does the patient feel the spasm? Do the patients have chest pain while you were doing this? We have EKG connected. Is the EKG showing evidence of ischemia? So all these parts of the provocative study tell us how significant is the spasm. If the spasm is very severe, if the microcirculation is impaired, these things tell us that the improvement after surgery is partial. Or maybe if the compression is not severe and the spasm is the severe thing or the severe problem, maybe this patient shouldn't go to surgery because decompressing the artery is not going to help. It's the medications to treat spasm that are needed.
That's exactly the question I was going to ask you.
Right. And so we may find cases in which we don't need to send somebody to surgery because we've identified that the cause of the chest pain is something else other than compression. So remember, unroofing releases or relieves the compression, but it doesn't do much for the microcirculation. It doesn't do much for the endothelial function. I will put a little bit of a caveat there is that I've seen some patients in whom the spasm improves after unroofing. And we have some hypotheses as to why that is. And we're trying to collect a number of patients that way to try to study them and report on that. But that's a sort of a secondary issue. Primarily, the unroofing is a treatment for compression, not for spasm.
Mm-hmm.
And at the least, as you said earlier, at the least, we just set the expectations right.
Some people will have their symptoms recur over time. In other words, they're symptom-free for some period, maybe a year, 2 years, 3 years. Why is it that the symptoms might manifest themselves after some time post-surgery?
I don't think the bridge grows back. I think if there is growth over the part of the artery that has been released, that growth is growth of scar tissue, not muscle.
Mm-hmm.
So I don't think it's a matter of reformation of the bridge. I think it might be progression of endothelial dysfunction.
So the process to relieve the compression doesn't necessarily heal. If you have endothelial dysfunction, it doesn't necessarily heal the endothelial dysfunction. That could still progress.
Correct.
Okay.
And that's where medical therapy is needed, where you want to treat with medications that prevent spasm, that control spasm, medications that maybe improve endothelial health over time.
Mm-hmm. I'm going to deviate here simply because I do know some people have had the bypass, present company included. If the artery that is giving you the trouble, which is the LAD that's bridged, you go through the unroofing process, you had severe vasospasms as well as, a compression issue that was identified or a blockage at the point of entry, which is common.
It's common.
That bypass then is now running through an artery that never had endothelial dysfunction. But is it still possible, but the original LAD that still has some flow could cause you problems?
Less likely so. So when the bridges are very severe and compressing so much that sometimes we even get that pressure gradient I was telling you about, that drop in pressure, even at rest or with very minimal dobutamine stimulation. In these cases, and in the cases in which you mentioned when there is an obstruction at the mouth of the bridge, which is also not a rare thing.
Yes.
If that obstruction is severe enough, in those cases, a bypass is reasonable. We generally do both unroofing plus bypass at our center. And we think that there is something to be said about the degree of compression and the triggering of spasm that can be caused by the compression. And so we think that unroofing plus bypass is better than bypass alone, although I don't think we have all the data to support that, just based on some of our local experience. If you have a bypass, you're much, much less likely to be affected by the native LAD upstream from the bypass. That's not going to be an issue for the most part. What you may have is endothelial dysfunction that is still there downstream. You may have microvascular disease that is with high resistance to flow still downstream. So you may have fixed a part of the problem, which is the large vessel problem, but you haven't fixed the problem on the micro level. So this may be another explanation why symptoms can persist or symptoms can recur after some time.
Okay, so that is a symptom in a situation, this endothelial dysfunction, that could deteriorate over time.
Absolutely.
Okay, and having nothing to do with the compression of the bridge.
No, because we were saying that the compression has been relieved by the unroofing.
Right.
So yeah, so what is more likely to happen over time is progression of endothelial.
Boy, I'm so happy to hear that because I think that answers questions for a lot of people. And then they know that's treatment medically.
Correct.
And something they would have to do. If somebody does have their symptoms recur and the suspicion is that it could be microvascular, does that then necessitate another provocative test?
Yeah, it gets a little trickier there.
Okay.
And the reason I say that is because if they don't have a bypass, yes, we can repeat the provocative testing, and we can repeat the microvascular testing, and we can repeat all the tests that I mentioned earlier, the ultrasound, the microvascular function, the dobutamine. We can repeat all that. If they do have a bypass, it gets complicated because we don't know for sure what the cutoffs and the normal values would be in the presence of a bypass. Most of the studies, or all the studies done on microvascular function testing, were done on native arteries, not bypass. So that's one thing. The second thing is, yes, sometimes if the symptoms recur after unroofing, the first thing we think about is endothelial dysfunction. And so we may opt for one or two things. We either try to treat endothelial dysfunction and treat for spasm, because that's what wasn't treated by surgery. Or we can, if we want to be more targeted and more precise, we go back to the cath lab and we repeat the studies as you said.
Provocative test. Can it be done on a bypassed artery?
Yeah, it can be. It's just that it depends on the degree of disease. And sometimes if you have severe enough disease, most arteries will have endothelial dysfunction with severe enough disease, and most arteries will have some degree of spasm. So if the artery is significantly diseased, I would say the result of the test becomes more nonspecific.
Is it possible, and I've not had this question, I have not asked this question of any of the surgeons or cardiologists that we've spoken with, endothelial dysfunction, can it be severe enough to cause sudden cardiac arrest?
Okay, so that's a good question. So coronary spasm has been known to cause ventricular arrhythmia and cardiac death. And as we mentioned, these patients have a higher tendency to develop coronary spasm. And so the yes and no answer to your question is yes, it can. The a little bit more nuanced answer is it's very unlikely, it's very rare. And I don't want to be, I don't want to be too sensational here.
Alarmist, correct.
Yeah, it is not likely, but yes, it has been reported, to be fully transparent.
Okay, and good to share, because people can be aware that it's very unlikely and that they can be treated medically.
Correct.
So once we've confirmed that a patient's most likely suffering from something that's microvascular disease or dysfunction, what are the next steps?
Yeah, so if the issue is microvascular disease or microvascular dysfunction, then the next steps would be medical management and both pharmacologic and non-pharmacologic management. So at this point, we will try to move away from surgery, because then our logic would be surgery may relieve compression. Compression is probably not the big player here, or not the culprit for these symptoms. So let's avoid the risk of surgery because we don't think it's going to help. Mm-hmm. Let's focus on the things that may help. So we think of conservative therapy or medical therapy, as pharmacologic or non-pharmacologic. Non-pharmacologic things are exercise, regular exercise, good diet, weight management. Really important. Weight loss is really important for people who are overweight, is really, really of great value. And we see that clinically all the time. Mm-hmm. Symptoms do get better as we lose weight and get in good shape, physically good shape. And then we manage all the issues that these patients have as far as high cholesterol. You need to get a statin and drop their cholesterol aggressively. High blood pressure, not allowed. We need to control the blood pressure. If we have to use 1 or 2 or 3 medications, we need to do that. Diabetes, same thing. Smoking is a big no-no. So we manage the risk factors. And then for the specific medical therapy, we will look at the endotype a little bit. So if we have epicardial spasm, we will focus on calcium channel blockers like diltiazem and verapamil, and we can also use nitrates. If we have microvascular spasm, I prefer to use a beta blocker. If we have just a simple non-endothelial dependent microvascular dysfunction, I use also a beta blocker and maybe a sodium channel blocker like ranolazine. So it depends on the endotype. And, we know from Cormica and other studies that when we identify the endotype, we're actually more effective.
Dr. Ziada, you mentioned something that I hadn't thought of, but in the process of identifying the microvascular dysfunction as one part of the disease, you can also have microvascular spasms as well?
Yeah. So microvascular spasm is a term we use for what we call for evidence of endothelial dependent microvascular dysfunction. So what that means is that when we inject acetylcholine, there are three things that can happen in a patient who is susceptible to spasm. One is that they have spasm, that we see spasm on the screen. The big arteries constrict. Two is that they have chest pain. And three is that their EKG shows signs of ischemia. When you have spasm on the screen, meaning the large vessel constricts, and when we say constrict, we mean very, very severe. We call it more than 90% constriction before we actually label that as vasospastic. That obviously is vasospastic. We got the diagnosis there, it's large vessel spasm. But sometimes when we see a patient having symptoms, chest pressure, chest pain, sometimes even they say, that's how I feel at home. That's exactly how I feel when I go up the stairs, something like that. And we see EKG changes. What that tells us is that acetylcholine is doing something, but we can't see it. So it must be doing it on a micro level. So that's why we call it microvascular spasm.
I see.
In essence, it's the better term, but it's a mouthful. So that's why we don't use it all the time, is endothelial dependent microvascular dysfunction.
Well, you did a very good job getting that out.
I had to catch my breath first. And then...
Is microvascular disease something that deteriorates over time, assuming the patient is taking good care of themselves? Obviously, if they're not, we would expect a deterioration. But if they're managing their health as you expect and keeping the weight down and exercising, does the microvascular dysfunction then maintain, or does it deteriorate regardless?
It doesn't have to deteriorate regardless, but I would not be honest if I say that you can make it go away. So when patients ask me that question, I usually tell them it's like high blood pressure or diabetes. You take the medicine and you keep the symptoms at bay, and you try to do the best things possible for the health of the endothelium and the microvascular structures. And then it would be hopefully stay the same, and maybe the symptoms will be under control. But I can't tell a patient with high blood pressure or diabetes that the medicine I'm giving them is curing them from the condition. So this one is about the same thing.
Sure. And it's likely that if you have this condition, doing nothing it's not going to heal in any way, shape, or form. It's not going to change.
It's not, and it's doing nothing, meaning not taking good care of yourself, whether pharmacologically or non-pharmacologically, can make things worse.
In terms of somebody who has had the unroofing procedure, let's say they didn't have any severe endothelial dysfunction. The compression was actually causing a problem, but they also did have a microvascular issue, but everything stopped on the unroofing. So obviously they're still presenting with problems, but we know that the hemodynamic issue of the LAD is fine. Now we know it's a microvascular situation. What happens for those people? What should they do?
Yeah, so if there is doubt about what the cause of the problem is, we can retest, like you mentioned earlier, and we can test through unroofed arteries. That's not a problem. We've done that a few times. What they should do would be to, focus on the microvascular dysfunction as a medical issue, meaning exercise, weight loss, good diet, take the medications. Sometimes the medications, it's a little frustrating because there is no one recipe for microvascular dysfunction. We have to individualize the therapy and the combination of things that we use for every patient. And so it takes a little bit of time, but eventually I tell everybody, almost all of my patients feel better. Not all of them, but almost all. A very small fraction of patients we hail to control their symptoms. Some patients feel a little bit better. Some patients feel great, but almost everybody feels better to some extent. So we work on that, and we get them to feel better, and we get them to be able to do the things they want to do on medical therapy.
Which is excellent. That's great to hear. And quality of life is so important. If we can take it from 30 to 70. That's huge. That's a big difference.
Correct. And it's a partnership. And so your listeners, if they are, if they had microvascular dysfunction and they have a physician that they've been working with, that this is a relationship, and there's a lot of back and forth, whether you're focusing on how to get them to do the things they want to do.
Yes.
So it's not what I care about, it's what the patient cares about. If they want to run, if they want to, go to Alaska, if they want to do this or that, it is sort of my mission to try to make that happen.
Mm-hmm.
I may not always be able to, but at least I try to do that. And then the other thing is we manage the medications. Lots of things that to do with that. The efficacy of them, are they working? Are they not working? Side effects, are the side effects tolerable? Are they not tolerable? Sometimes even now we worry about cost. Can we find something that's cheaper? Can we find something that does the same thing? I mean, we have to get into this relationship where we cover all the bases.
Mm-hmm. One of the things that comes up, and people have enjoyed when I ask the surgeon, interventional cardiologists that we speak with, is something a little bit personal. I mean, you have a highly, highly stressful situation. It is life and death. And you are in our hearts all day long. What is it you do to relax? How do you take a break from the intensity of the role at Cleveland Clinic?
Okay, so I exercise. So that's one thing. And I'm a big, crazy soccer fan. So I used to play, but I don't play anymore because I hurt my back. But I watch a lot of soccer. I travel to watch soccer. I go to Europe to watch soccer. I go to the World Cup. I do all the things that, the crazy soccer fans do.
Be careful now. I hear those crazy soccer fans. They mash each other.
Yeah, I try not to get into those, but it's something that it's one of the things where I sort of block out and just enjoy the game like everybody else who does enjoy the game. I watch a lot of sports, but soccer is my thing.
Is there anything that you would like to leave our listeners with before we conclude? And we really don't know much about Cleveland Clinic because I haven't spoken to anybody from Cleveland Clinic yet. Maybe share a little bit more of the operation and the significance of what you do.
Yeah, I'm happy to do that. For your listeners, I think it's important to know that we are here for you. We have a lot of resources. We have all the testing that is needed. We have great surgeons. Some, maybe at least 3 or 4, have great experience in bridge surgery. We pride ourselves on running a very coordinated and comprehensive operation. So when patients come to us, we take care of everything from the medical side, from the surgical side, from the coordination, from the testing, all that, if that is needed. We do a lot of second opinions and a lot of third opinions even.
Oh, I'm great to hear that.
That's a good role to have. Sometimes, especially these issues like myocardial bridges, microvascular disease, the care may not be available to everybody everywhere. And so we're happy to do that. We do that sometimes virtually, sometimes in person, depending on the exact needs. My group here as an interventional group, I do a lot of microvascular testing. A few of my partners do some to help me. We take care of our patients directly. The model changes from one place to another. Some centers, the interventional cardiologist does the testing, but the medical care is taken over by a clinical cardiologist. We don't have that. It's just you get one doctor who takes care of everything as far as we're concerned with microvascular and bridge testing.
Mm-hmm.
And we offer Midwestern hospitality. We're generally easygoing. We don't have big egos and big problems. We like to see patients. We like to help patients. And so hopefully we're able to help as many people as we can.
You certainly were one of the institutions that was referred. As I started my process, you were just in Cleveland and I happened to be in California. Stanford was closer. However, we do know of a famous name who happened to be our governor who went to Cleveland Clinic to have his heart work done. So Arnold Schwarzenegger, and I would say there's an ego there, but he chose Cleveland Clinic for his work.
He came here and he's very popular here. He won a lot of hearts here. Now he was just being very nice and gracious when he was here as a patient. And he still send thank you cards every year to the team, and they post it up on their wall. And so, he's been very nice to the clinic, and hopefully he's doing well. I think he is doing well.
It seems like I know he's working on another movie at this point.
Well, that's a good sign.
Yes. So what would be the next steps if somebody's interested in getting in touch with you to either get a second opinion or just originate a conversation?
So you can find me on the Cleveland Clinic website. You can use my email. I don't know if you can post my email.
I'll stick it in the show notes, yes.
I'm happy to answer emails. That's probably the best way to get me is through email. And we do have on the website, at the Cleveland Clinic website, we do have a process for virtual second opinion. We have a process for getting appointments and so forth. But maybe sort of an informal way probably the fastest way is the email.
Okay, fantastic. And I would expect that you're going to hear some things. You might even get some soccer fans who are going to reach out and see who your favorite teams are.
I'm happy to get in that conversation too.
I'll bet you would be. You guys are rabid. It's like our football fans.
That's right.
Well, Dr. Ziada, this has been such an informative discussion, and it's one that's been most necessary because we're starting to hear this microvascular dysfunction disease more and more and more as people are actually getting their provocative testing done. And so for any of us that have been on roof, we recognize the fear that we've got is we don't want this to come back. We're happy that we think we've alleviated it. And you've also helped us understand that it is possible. It's endothelial dysfunction. And I think that's really helpful because many of us think, oh my gosh, is the bridge grown over it? Has the scar tissue grown? Has it made it compress again? Do we have to go through this surgery again? And in most cases, that's not going to be the situation. For what you do, for what the entire team at Cleveland Clinic does, I thank you from the bottom of my imperfect heart and really appreciate the conversation today. So thank you.
You are very welcome, Jeff, and it's my great honor and privilege to talk to you today and to your listeners. And as I said, we are here to help, and that's our pride and joy is to try to help patients and help people. So I welcome any contact, any second opinions, any informal chats. I'm happy to be there for all your listeners.
Excellent. Thank you. Thank you for listening to Imperfect Heart. It's my hope that this information helped in some way to improve your situation or will help you better understand this condition. More importantly, that it gives you hope through stories that there is help and you most certainly are not alone. If you've been diagnosed with a myocardial bridge, please be sure to join the private Facebook group, Myocardial Bridge Support Group. For more information about our program or to reach me directly, visit the website, myimperfectheart.com. If you like what you heard today, please give a positive review, thumbs up, high five, or whatever your app likes. And be sure to share with everyone important to you so they understand what it is you're dealing with. Please subscribe as well. Welcome each day with gratitude and positivity. The views and opinions expressed in this program are solely those of the host and the guest and are not intended to provide, nor are they a suitable substitute for, professional care by a doctor, therapist, mental health professional, or other qualified medical professional. Imperfect Heart is a production of Hear Me Now Studio.